And the least common location of ectopic pregnancies is the intra-ovarian ectopic pregnancy. This is a patient who was pregnant, had some bleeding. You can see that there's some fluid within the endometrial canal with a little, you can see the echogenic endometrium around it. This would be consistent with a pseudo-gestational sac. And when you looked at her ovary, you can see this echogenic tubal structure within. You can actually see a yolk sac in it. It clearly is surrounded by the ovarian parenchyma. The only way that you can differentiate this from a corpus luteal cyst is by this identification of the yolk sac. Now, I have said earlier that occasionally you can have fibrin stranding or debris that could mimic a yolk sac or an embryo. So again, hard to know for certain, but this was surgically proven to be an intra-ovarian ectopic pregnancy. And the last thing one needs to talk about in terms of location of ectopic pregnancies is, of course, the heterotopic pregnancy. In other words, two pregnancies, one within the endometrial cavity, a normal intrauterine pregnancy, but an additional pregnancy within the adnexa, so both an intrauterine and an extrauterine pregnancy. As I said at the outset of this lecture, this incidence is extremely low in the general population, estimated to range from 1 in 7,000 to 1 in 30,000 pregnancies. But the incidence is substantially increased in women with multiple risk factors for ectopic pregnancies. So women who've undergone in vitro fertilization, ovulation induction, PID, and tubal surgery. And these risk factors are additive. So in a woman with multiple risk factors, her risk for having an intrauterine and extrauterine pregnancy may be quite high as 1 in 3 per 100 pregnancies. So this is a patient who'd undergone assisted reproductive techniques, gotten pregnant, and you can see here there's a little intrauterine gestational sac. You can see the embryo and the yolk sac. It's eccentric. You could even describe this as a cornual pregnancy. But if you look carefully, in fact, there is a second gestational sac here in the left interstitial region. Notice there's myometrial tissue around part of this second gestational sac, but part of it is beyond the serosal confines of the uterus. You can see a little bit of normal myometrium between the edge of the gestational sac and the edge of the ectopic pregnancy, confirming that this is a heterotopic pregnancy with the ectopic being interstitial in location. This is a patient who had an IUP here. You can see the yolk sac, had an ectopic pregnancy here in the left adnexa, also with the yolk sac. And both of these gestational sacs contain little embryos, and both of them demonstrated cardiac activity. Another patient having a little gestational sac within the uterus and actually a much larger gestational sac in the left adnexa. Here you can see the yolk sac and here the little embryo, consistent with heterotopic pregnancies. And another case where you can clearly see an intrauterine pregnancy, the yolk sac and the embryo. Here is the uterus, here is the endocervical canal. But when you look where she hurts, between the right ovary and the fundus of the uterus, notice we could only see this on transabdominal imaging. You see this echogenic tubal ring, again, another patient with a heterotopic pregnancy. And I believe one last one to show you. Here you can see an intrauterine pregnancy. That's number 1. Number 2 is this interstitial pregnancy here. And number 3 is an ectopic pregnancy within the tube between the right ovary and the fundus of the uterus. And one more. An intrauterine pregnancy here. You can see the yolk sac. And here you can see the corpus luteal cyst, the ovary, the fundus of the uterus. But way up high, you see another tubal ring. And so again, a patient with a heterotopic pregnancy. So it's been my experience that the incidence is actually probably increasing a little, and not all of these seem to be related to assisted reproductive technique, but certainly in those patients you need to be particularly careful to look for both an intrauterine and extrauterine pregnancy. So in conclusion, when you have a patient who is pregnant in the first trimester and presents with pain and vaginal bleeding, you do need to evaluate the patient for an ectopic pregnancy. But you should remember that about 70 to 90% of all of such symptomatic patients actually turn out to have an intrauterine pregnancy. In terms of making the diagnosis of an ectopic pregnancy, you need to use both endovaginal imaging and transabdominal imaging. Remember to magnify the images and be particularly careful to look where the patient hurts. In terms of the ultrasound findings that will help you make the diagnosis, look for the extrauterine gestational sac. You can be 100% positive of your diagnosis if you see that echogenic tubal ring containing the embryo, cardiac activity, or a yolk sac, but you can be fairly certain of the diagnosis even if you see just an echogenic tubal ring. The next most likely or next most specific finding will be the presence of the adnexal hematoma, which will be much more amorphous and variable in appearance. Turn on it 90 degrees to see if you can identify the tubular configuration, magnify it, use color to see if you can see the yolk sac, use color Doppler to see if you can see trophoblastic flow, and don't forget to look for free fluid both in the pelvis and in the upper abdomen. Remember, that may be the only finding of ectopic pregnancy in some patients, and it's also very, very important in terms of assessing patient hemodynamic stability. And in all cases, you need to correlate your ultrasound findings with the serum beta-HCG level, the date of the last menstrual period, and in many cases, you may need to do a follow-up ultrasound examination or beta-HCG level in order to confirm your diagnosis. Thank you very much.